The broadcast is now starting. All attendees are in listen-only mode.
Well, we're going to go ahead and get started. So welcome. I wanted to welcome everyone to tonight's webinar. I'm your host, Dr. Lauren Levine. Many of you know me as the Digital Dentist. We've got a great speaker, a great topic, and a lot of people registered. As of this morning, we had over 800 people that are registered for the webinar. I think it's because of what I had mentioned earlier, great topic and speaker. A lot of people are here. A lot of people are logging in as well. I'm only going to speak for a couple of minutes or so. I want to make sure that Dr. Kosinski can speak for as long as he wants. He had also said he wants to make sure that we leave a fair amount of time at the end to take as many questions as possible. Most of you have been on webinars in the past. You know the format, but if it's been a while or this is your first time, on your screen you have a GoToWebinar control panel. You can go ahead and type in your questions as you think about them. We typically don't get to the Q&A until the end of the presentation, but we will answer the questions in the order that we receive them. So just type them in as you think about them, and we'll definitely make sure that we get to them at the end. By tonight, I will send you a couple of things. You're going to get an email with links to download. This entire presentation is being recorded. So don't worry if you've got to take a phone call or, got to take care of the kids or whatever. You're not going to miss anything. You can download the entire presentation afterwards. They are providing continuing education credits as well. That's going to take a couple of days. We ask that you be patient as it obviously takes a while to process 800 CE forms, but those will go out shortly as well. So that's about all the housekeeping I want to do, and it really gives me great pleasure to introduce Dr. Tim Kosinski. I've done a number of webinars with Tim in the past, and if I had to read his entire bio, we'd have no time for the content. He is very, very accomplished, and I'm so pleased to be able to introduce him again. He's an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He serves on the editorial review board of Reality, the information source for aesthetic dentistry, the Michigan Dental Association Journal, and he's the editor of the Michigan Academy of General Dentistry and associate editor of the AGD. He's past president of the Michigan Academy of General Dentistry. He got his DDS from University of Detroit Mercy Dental School and his mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry, the International Congress of Oral Implantologists, and the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry and received his mastership in the Academy of General Dentistry. He also received many honors, including the fellowship in the American and International Colleges of Dentists and the Academy of Dentistry International. He's placed over 13,000 dental implants and published close to 200 articles on surgical and prosthetic phases of implant dentistry. He's been a contributor to a number of textbooks. He lectures extensively around the U.S. each year, so make sure you look for him in any upcoming events that you may be attending. And with that, Tim, it gives me great pleasure to introduce you, and we're looking forward to tonight's presentation.
Wow, thanks, Lauren, so much. I really appreciate the invite again, and I think we have a very important topic for our attendees today, and I see that we have a big group tonight. I'm going to cover a lot of information that I think is going to be very useful. And for those of you who maybe have heard me in the past, I'm a big believer. I'm a general dentist in the Detroit area. As you mentioned, we place a lot of implants. I have a great team behind me. But you have to remember, Detroit was one of the hardest hit economies in the country, and yet this lowly general dentist from Detroit is doing a lot of dentistry. And so I challenge all of you out there, all the listeners out there, to absorb some of this information and educate yourselves, and certainly grow your practice with something that I think is very critical. I know that many GPs out there in my lecturing decide not to do extractions, and I'm always a little bit amazed by that. So hopefully we're going to be able to show you some of the techniques that I use, the practical techniques that I use, that make extractions rather simple for me. I'm a big believer in the term atraumatic extraction. And what does that mean, Lauren? Well, that means, atraumatic to the patient. making extractions easy. You know, we all know that dentist that puts his knee on his or her knee on the chest of a patient to get a tooth out. Well, we don't need to do that anymore. And I'm going to show you briefly some techniques that I use that make extractions, even the most challenging extractions, fairly commonplace. We also want it to be atraumatic to the bone. And our program tonight is predictable extractions and grafting options for any experience level. And so we're going to talk a little bit about the grafting procedures that I use in my practice, and simple socket grafting procedures, and even more complicated ones are a viable alternative to leaving a socket exposed. We all know that when a tooth is removed, bone is going to shrink. That's just physiologic, and it creates all kinds of havoc for those of us who want to place an implant in an area. What do we see in the posterior mandible? We see that horse's saddle look as the bone shrinks down and in. We're concerned about the mandibular nerve in that area, and so we get a little bit afraid of the vital anatomy. In the upper jaw, we're concerned with the sinus. Again, when we remove a tooth, the root of a tooth acts like a tent pole holding up a circus tent. And if we remove that tent pole, I'm going to have to come up with a different analogy with circuses going away, but I think you all understand what I'm saying. When we remove that tent pole, the circus tent is going to collapse, which makes placing implants in the posterior maxilla very challenging to most of us. So our socket grafting procedures following an atraumatic extraction is an important tool that helps us maintain bone. And finally, the third thing that I like to discuss when we're talking about atraumatic, we said atraumatic to the patient, atraumatic to the bone, also atraumatic to me. As I'm getting older in my practice, I think it's imperative that I save my body. And that means saving my hands and my arms and my back and my eyes and my ears. And so using a technique that prevents me from really putting a lot of pressure on a tooth, where there's no forearm or bicep or shoulder pressure in my extraction, it's going to allow me to practice for a much longer time. So we have a lot of information to cover. Again, I'm going to show you the practical things that I use in my office. There's 100 ways of doing certain procedures. I'm not going to go through all 100. I'm going to show you what works very successfully in my hands, and hopefully you'll be able to take this information and use it in your practices as early as tomorrow. So questions that I have: are you performing most of the extractions in your office? If you're not, why not? Well, we briefly touched on that. You're not because we've had issues, right? We have a myriad of instruments. If you're going to do an extraction, your staff member brings a big bin full of instruments, and you might ask yourself, why do we have so many instruments? Well, because we need them. We have situations where extracting a tooth or a root tip can be very challenging. It can be very stressful to us in our practice, and it can take a lot of chair time away from us, and the financial rewards just may not be there. We've all had those times where we have dinner reservations or a function to go to. We have an emergency patient, and we end up fracturing a root tip, and we end up spending valuable time trying to get a fractured tooth out. Or worse, we give up and we leave it. And I see that way too often in my practice with all the implants that I do. I see a lot of left root tips in edentulous spaces, which is a little alarming to me. So we have to demonstrate some techniques that I think you'll find very useful in your practice. Are your extractions predictable in terms of the results? If not, why not? Well, maybe you're using the wrong instrument, or maybe you weren't taught properly, or you don't have the competence and confidence in being able to remove a tooth. Near the end of the program, I am going to discuss some of the teaching programs that we do along with GoldenDent at our University of Detroit Mercy Dental School. We have two pretty amazing programs, and Kurt with GoldenDent will describe them at the end of the program. But one is, we call it Amplify One, which is a full day atraumatic extraction course where our attendees, we limit the attendees to a smaller number. We may see 80 patients at the dental school, and every participant may end up taking 20, 30 teeth out using the techniques that I'm going to demonstrate. What better way to learn than on existing patients? And then the second program is even more dynamic. We call it Amplify 2, which is a little more involved. It's a 2-day program taught by Dr. Arne Azarian, a very prominent dentist here in the Detroit area, and myself. We do a day of lecturing at one of the nicer facilities in the city. And on the second day, we go again to our dental school, University of Detroit Mercy, where we may treat 65 to 80 patients. And what's unique is not only will we do extractions, but we will teach you on live patients our grafting techniques, some of the grafting techniques I'm going to demonstrate tonight, where we can do socket preservation, or even if we do have a tendency to fracture or lose a facial plate of bone, we can show you how to predictably repair that. Again, I'm going to touch on that in my program tonight over the next 50 minutes or so. But again, being able to do these procedures on patients is invaluable. So you may want to contact Golden Dental and get more information on those programs. Are you currently offering grafting to your patients in your practice? If not, why not? Well, I think that grafting is a very, very important part of any general dentist practice, especially if you're doing atraumatic extractions. Even my dear friend and probably one of the most respected lecturers in the country, Dr. Christensen, will tell you that this is an important discussion that you must have with your patients. Bone is gold to us, especially those of us who are in the implant field, and maintaining bone is a very, very valuable to our patients. It's also very, very financially rewarding to you out there, the general practitioners out there. It's a procedure that doesn't take a lot of time, is not an expensive procedure, and is very lucrative as far as providing a service. I think that we can't make the final decision for the patients whether or not they want a socket grafted or preserved. However, I think it's important that you do take time with your patients and explain what can happen if you don't graft a certain socket. Again, we know that if a tooth is removed, physiologically bone is going to shrink, and tell your patients this. It's going to shrink down and in the lower jaw and up and in the upper jaw. And that bone, once it's lost, it's very, very challenging for us to grow the bone back. So if the patient decides they want an implant in the near future or distant future, trying to get bone once it is lost is very difficult and very costly. Oftentimes we have to refer to our oral surgeon colleagues, and they will do an autogenous block graft where they'll take bone from the chin or from the back of the jaw and actually screw pieces of bone into the edentulous space. This is very expensive to the patient. So again, they can pay you a little now or pay a lot later if they deem that they do want this type of therapy. So we're going to discuss all that throughout the program, and hopefully you'll find this information very useful. Are you getting the clinical results? Some of you out there may be attending, and we have a lot of people watching right now, maybe are doing the procedures but not getting predictable results. Maybe you've taken a course and you didn't get the results you wanted. You went back and tried to place an implant and it was mush. Well, I'm telling you, with the procedures that I'm going to demonstrate in this short time with you tonight, we can grow bone 100% of the time. But it is very technique sensitive, and we have to follow the protocol. I know as dentists, sometimes we don't like to follow all the steps, but I think it's imperative that we follow the steps that are going to be demonstrated. And if we do, we can grow bone very, very predictably. And I think you'll be very excited about your results following this short lecture. Maybe you think that your patients don't want to pay for the expense of grafting. Well, that may be very well true. Dental insurance oftentimes will not cover the cost of the materials or the procedures themselves. But I think it's your job as a dentist, as a professional, not to sell a procedure to your patients, rather to educate and instruct and make them aware of the benefits of the procedure, and also what can happen if we don't do this procedure. That's our job. That's part of our profession. And I think we touched on that already. A bone loss is a very serious consequence of not grafting a certain procedure. I hope many general dentists out there are willing and interested in placing implants. But you also, if you're going to place implants, you have to feel comfortable doing atraumatic extractions and grafting procedures. I like to use the analogy of my wife. Here in Michigan, we have a very short summer. She works very, very hard in April preparing the garden beds and flower beds so that we can have beautiful fruits and vegetables and flowers here in August, and we're starting to lose them now in September. But we have to prepare the site to get ideal results. So grafting atraumatic extractions is an important part of implant dentistry. Just as a quick commercial, I am involved in a couple programs with implant dentistry. I do a 2-day program through Glidewell Dental Lab. You can contact them directly if you're interested. I do those all around the country. And I'm also involved in the Engel Institute here in Detroit, which is an interesting program. It's 3 days, 2 days of lecturing, and on the third day, you'll actually come into my office and you will place an implant in one of my pre-selected patients under a very strict protocol, under direct supervision of myself or one of the other mentor dentists. So if you're going to get involved, you jump in with both feet, and I strongly recommend that all the GPs out there become educated, confident, and competent in their implant procedures. I know that all our practices are very unique, and I talk to dentists from all over the country. We're all different, but I think it's important that we slow down and listen and learn procedures the correct way. The procedures that are done, they're not magic. They're protocol, they're step procedures that once followed will give us magnificent results. So again, I'm going to just share my experience and how I have successfully implemented atraumatic extractions and grafting into my practice. I'll keep it simple and basic, and something that all of you who are listening tonight can certainly accomplish. So our objectives, very briefly, we're going to just do a general overview of the different grafting materials and membranes that I use, and we'll do this through clinical case discussions. We're going to do step-by-step instructions how to immediately implement predictable grafting procedures in your practice. We'll talk briefly about the atraumatic extraction techniques that I use using the Golden Dental Physics Forceps, and we will talk and we will kind of reinforce why it's important to graft and how best to explain these procedures to your patients. Let's start with some clinical cases. And one of the nicest products, and I'm going to slow down, I know I'm talking very quickly because we have a lot of information to cover, is something called the OsteoGen plug. And if you don't write this down, you'll get a copy of this from Golden Dental or from Lauren. OsteoGen plug is an incredible tool that I use in simple socket grafting. So very typical. We have a non-restorable tooth. I hope you all agree that this is a tooth that we probably don't want to do a root canal, post and core, crown lengthenings, and trying to save it. At least that's not what I would do in my practice. I would explain to the patient how this tooth is non-restorable. They understand it. It has odor. It hurts. It's sore. We want to remove the tooth. And wouldn't it be nice to be able to remove this tooth and the patient looks up at you when you're finished and say, wow, really? Well, wow, that was the best extraction. Well, that's incredible. I didn't feel anything. And so we will teach you these techniques in our University of Detroit Mercy programs. I would infiltrate this site. We use a buffered anesthetic from Anutra. It's lidocaine buffered with sodium bicarbonate, which increases the pH to a physiologic number of 7.2. I don't block my implant cases. I would infiltrate, maybe do a PDL. And you can see this tooth is non-restorable. This may be a challenging extraction for some of you. maybe not so much for others, but I'm going to go through the procedures of what I would do in my practice. These are a wonderful set of instruments from Golden Dental. They are instruments that I find invaluable. I'm going to start from the bottom up. We have two instruments that are called separators. These separators are serrated and allow me to access the socket area between the root of the tooth and the available bone. So what I'm doing is expanding the facial plate of bone, especially to allow me to remove the tooth atraumatically and simply. I always try to maintain the facial plate of bone whenever possible. But those of us out there know that sometimes we do damage the facial plate of bone. I'm going to show you how to repair that. The second instrument, the second one from the bottom, is called the bayonet. This is a wonderful instrument for me to remove small root fragments or root tips. The root tip elevators are angled. You can see the handles have substance to them, which allow me to elevate teeth out of the socket. And then we have these micro serrated cutting tools that, again, are very sharp and allow me to cut around the periodontal ligament quite effectively. A wonderful set of tools, and you can see that they're blue tipped or blue colored, and that's a plasma vapor deposit which makes the instrument stronger and less scratch resistant. So these are high quality US made products that I think that you should look at, and Kurt at the end of the program can discuss any kind of specials or whatever they have. These are instruments that I use just about every single day in my practice. So here you can see I'm using the serrated separator, and I'm going between the root of the tooth and the available bone. And I'm luxating slightly to spread the bone to some degree. Now, the physics forceps, for those of you who have seen my YouTube videos or some of my publications, know that I'm in love with this tool. I would not practice without the physics forceps. In my hands, it is absolutely magic. Of course, there is a learning curve involved with it, but I've already demonstrated or talked about some of the courses that we have where you can learn to become very proficient. The instrument consists of two components. The beak is the flat shovel-shaped edge, which will engage the palatal or lingual aspect of a root, about 1 to 3 millimeters subgingival. It is the working end of the instrument. The second component is referred to as a bumper, and that's the green part at the top of this screen. The bumper is not the working end of the instrument. Rather, it is simply a fulcrum, a center of rotation. We do not squeeze the handles of this instrument. Rather, we are simply holding them and twisting our wrist. We're twisting our wrist to create tension onto the beak of the instrument, onto that lingual or palatal aspect of the root. This tension created on the lingual or palatal will create a physiologic response. That physiologic response is a release of enzyme into the periodontal ligament area. That enzyme will destroy the periodontal ligament. So what is holding that tooth in place? It's not bone, it's the periodontal ligament. If the periodontal ligament is systematically melted away in about a minute, the tooth will then elevate up and out of the socket. Now, we call this a physics forceps, and I wish they didn't ever call it a forceps because it's more of a luxator. It's lifting the tooth up and out of the socket. I'm able to maintain facial plate of bone miraculously with this instrument when it's used correctly. The standard set of instruments, and again, Kurt can go through this at the end, is a series of 4 instruments. 3 in the maxilla, an upper right, an upper anterior, an upper left, and a lower universal. And again, here I'm going to demonstrate that case. I'm engaging that beak 1 to 3 millimeters subgingival. I have to have a purchase point with this instrument, and if I don't have a purchase point, I have to create one, and I'll create one using a 557 long surgical burr, and I will simply flatten the lingual aspect, on this case, the lingual aspect of the root, so that that flattened beak can be engaged. The bumper is placed as far down in this situation, down into the vestibule as possible. I do not squeeze the handles. There's no forearm, no bicep, no shoulder pressure whatsoever. The patient isn't feeling their head rock back and forth because I'm not squeezing the instrument. I'm not doing figure eights. I'm simply creating tension on that lingual aspect by rotating my wrist towards the patient's shoulder. In a minute or so, this tooth will pop. You're not going to hear it pop, but rather you're going to see this tooth lift up and out of the socket. And here I'm demonstrating I am not squeezing the instrument. Rather, I'm holding it in the palm of my hand and simply pushing down ever so slightly of my wrist, rotating my wrist, allowing that tooth to luxate. The instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth up and out of the socket 1 to 3 millimeters. I will then take what we call a tooth delivery instrument. Again, Kurt can talk to you about this at the end. And I will simply pull that tooth up and out of the socket, maintaining the facial plate of bone in the anterior aesthetic zone. Even more importantly than that, maintaining the inner septal bone, which will maintain my interdental papilla. I have a socket, my immediate post-op. This socket will be curetted and then grafted. When we're talking about grafting, it's important that we discuss or classify our periodontal defect. In our hands as GPs, what I want to demonstrate today is what I'm going to call a 4-wall defect, meaning all 4 walls are intact. We have a waffle cone or a cereal bowl, and we're going to be able to place whatever into that cereal bone. Rice Krispies, Cheerios, Cinnamon Toast Crunch, whatever. And with the procedures I'm going to demonstrate, we can grow bone predictably. We can prevent shrinkage of bone predictably. But every so often we lose a facial plate of bone, either through trauma of the extraction, ankylosis, or simply disease of the tooth, which cause an elimination of the facial plate of bone. I'm going to call that a 3-wall defect. But we can predictably, and I'm going to show you how we can predictably repair that with our techniques. So here we have that socket, and in our GoldenDent dental grafting kit, we have a sharp curette, and we want to eliminate any granulation, any infection, and any purple blood from that socket. So we're going to curette. Very, very important technique. Now, I mentioned the OsteoGen plug. This is something that I think every general practitioner should have in their practice. This is not collagen. This is a material that is a bioactive calcium apatite material, and the matrix is a bovine Achilles tendon, which is, it's kind of stiff. However, it's not so stiff that I can engage it into that socket and it will form fit into that socket. The material, that bovine Achilles tendon matrix and the calcium apatite, mimics the organic and inorganic components of physiologic bone. Now, how is bone grown? Okay, this is a synthetic material that is very inexpensive. It may be a $40 or $50 piece of material. We don't need a membrane with it. I'll talk about that in a second. I'm going to engage this into the socket forcefully. So I'm simply taking my instrument and I'm placing it. And it comes in various sizes, and Kurt can talk about that. It's a large and a small plug. It even comes in sheets. This provides a scaffold for bone formation. How does bone heal? When I'm talking to my patients, I will tell them we're putting this synthetic material into the socket to prevent bone loss. It's not concrete, though. We're not pouring concrete. It's not just getting hard. Rather, the body's cells will attack it and eat it away. We know that as osteoclasts. Then, right behind that, different set of cells is going to lay down new bone. We know those as osteoblasts. We know that a socket is going to heal from the apex towards the crest. What's nice about this material is, even though it may be relatively radiolucent upon immediate placement, over time, we can take a radiograph and objectively see the bone transformation. The bone transformation is going to occur from the apex towards the crest, though. So we're going to look more like bone at the apex. Over time, the crest will start looking more like bone. It doesn't wash out. It absorbs blood magnificently. It'll form fit into that socket. Some of the materials we have to mix it. You don't have to mix anything. And as bone fills in, we can objectively see the radiopacity change where we get bone formation. So I'm taking this material and I'm packing it into the socket and I'm forcefully plugging it into place. I'm firmly, it's not amalgam, I'm not crushing it, but I am forcefully placing it into the socket. And here we have a plugger, again, in our Golden Dental grafting kit, and this is what it looks like. Now, I do not need a membrane in this situation because the bovine Achilles tendon scaffold is a scaffold for keratinization for tissue to overgrow it. Tissue will not go into this material. It's just engineered magnificently. It's something that I've had tremendous success with, and I challenge all of you out there if you're going to do extractions. Now, I will put a caveat there. I use it when I have all four walls intact. When I'm missing a facial plate of bone, I will use other materials that I'm going to demonstrate in a few moments. So this, you can see how the blood absorbs into the site. I'm simply going to put a couple sutures. These are Vicro sutures just to hold that membrane in place, or the material in place. And this is what it looks like upon immediate placement. It's a little bit radiolucent. With time, it'll change over. Another example of an OsteoGen plug, we have a tooth that is deemed non-restorable. We're going to remove this tooth by using the physics forceps. Again, very simple. I'm engaging the beak on the lingual surface. I'm putting the bumper as far down the vestibule as possible, and I'm simply rotating my wrist without squeezing the handles towards the shoulder. The tooth will come up and out of the socket. This is a very important photograph that you're seeing. Do you see how that tooth is coming up and out of the socket? It's not coming facial. It's following that arc of rotation of the design of the instrument itself. The instrument is not intended to remove the tooth in total. Rather, I'll take a tooth delivery instrument and remove the tooth in total. Again, we're going to curette the socket site, removing any granulation, purple blood. Red blood is good, purple blood is bad. And here's the large size of OsteoGen plug. I'm placing it. You can see how the blood is just absorbing into the material. I'm firmly packing it into position and suturing without a membrane. A membrane, as we'll discuss in a little bit, is a very important part of grafting conventionally, in that epithelium grows about 10 times faster than bone. I've already said that a grafted site, the bone turnover will occur from the apex towards the crest. So we have a race between bone formation and epithelial ingrowth. So a membrane will normally hold that epithelium out of the way to allow that bone to turn over. But because of the scaffolding of the bovine tendon, we're not going to get invagination of epithelium into this material. And we're simply suturing, and in our courses, we'll teach you proper suturing techniques, just some cross stitches to hold the material in position. You can see immediate placement of the material, and we will allow it to heal, and this will be a site that I can place an implant in the future. Nice case. Here we have, very typical, a non-restorable maxillary first molar. We have bone loss around it, and we want to remove this tooth atraumatically. We're using our physics forceps. Again, because of the medullary bone in this site, I'm able to remove this tooth with one instrument. I don't have to remove the crown. I don't have to section. The crown came off. I'm creating a purchase point and removing these fractured roots using the physics forceps. And as you can see, we have bowling ball holes from a bowling ball. We have 3 definitive sites, we have granulation tissue. So what are we going to do? We're going to curette, 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 curette. You can see the immediate socket site. We're going to place our OsteoGen plug after careful curetting. And here I've taken a large particle size, large plug, and I've cut it into 3 pieces. I'm placing it into my socket sites, just as I demonstrated earlier. Some sutures to hold it in place. And this is what it looks like immediately after placement. 1 week post-op, I'm going to remove the sutures, and you can see the graft material in place. Now, epithelium grows extremely fast, 0.5 millimeter to 1 millimeter a day. This was a fairly large open site, right? It was 6, 7 millimeters. A week later, we just have a small, maybe 1.5 millimeters, 2 millimeters exposed. Once the sutures are removed, that will heal over very quickly. You can see over a period of time that the bone changes over. It starts looking like the surrounding bone. Now I can very predictably place a dental implant because I didn't remove the tent pole and didn't allow the circus tent to collapse. I'm going to do a flapless implant procedure. I know this isn't an implant program, but it's important for you to see what I'm doing. I'm taking a round circular punch, removing the soft tissue, and to prove, I've done a lot of histology. We've probably done probably close to 20 samples that we've had histologically evaluated. And here I'm taking a trephine, and I'm going to go ahead and create a sample. And we're going to have this studied. And very briefly, I know it's not a histology lecture, but you can see in a 4-month period, the vast majority of what was there is now new bone. We have osteocytes, we have osteoblasts, we have lamellar bone. We have very little of the OsteoGen material left in place. I'm telling you with my heart, when you have a socket with all walls intact and you use this plug, in 4 months you are going to have bone formation, which will allow you to take your practice to the next step. Here we're simply creating our osteotomy. I'm placing my implant. And here we did a CT. We have a Vatek CBCT in our practice. We see that we've elevated the sinus floor, and over a period of time we can restore that. So I think we can all agree that this is a pretty simple grafting option that you should be able to use in your practice immediately. It's about $50 a plug. I don't know what you're going to charge for your grafting procedures. You have to determine that individually. But you can see this is very financially rewarding and, most importantly, the right thing to do for your patients. So let's look at situations where an OsteoGen plug may not be indicated, where maybe we lost a facial plate of bone, or maybe we want to use allograft. You know, there's different graft materials. Allograft is bone harvested from another human. It's mineralized, demineralized, cortical, cancellous, particulate, 250 to 1,000 microns, but this material must be protected by a membrane. This is a very interesting case where this patient was referred to me for atraumatic extraction of a fractured maxillary cuspid tooth. And if you look closely, you can see there's a horizontal fracture. Where do we see it? Right at the post. Probably do more implants on teeth that have posts in it than anything else. So is this a difficult extraction for some of you out there? Well, I would say yes. It's a root canal treated tooth in a mature adult. We have porcelain restorations on either side of the space. We want to maintain the interdental papilla, which means we have to maintain interseptal bone. This can be a traumatic situation. Using a CBCT, we can see that the facial plate of bone is almost paper thin in the premaxilla. So these extractions can be very challenging. Again, using proper technique and protocol, we can show you how to remove these teeth quite simply. Again, I'm using the physics forceps. I'm engaging the palatal aspect of the root 1 to 3 millimeters subgingival. I'm placing the bumper as high up as possible. I'm simply rotating my wrist without squeezing the instrument. and I'm rotating my wrist towards the corner of the right eye. And in a matter of a minute or so, the tooth will pop. You won't hear it. It'll disengage up and out of the socket. It is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth, break down the periodontal ligament. I'll take a tooth delivery instrument and remove the tooth. Now look at the shape of that root. Now, this is a site in my practice where I would want to place a dental implant. But it's imperative that if you're going to place implants, you must have bone. You must have a facial plate of bone. Do we? Well, for education purposes, I did another, with our CBCT, we can actually take individual teeth. We can limit our field of view. And you can see that that facial plate of bone is indeed intact. We may have a little dehiscence right at the tip, and that's what I was concerned with because of that curvature of that root. To demonstrate, what I did was I made an envelope flap. There's no vertical incisions here. Again, these are all the things that we teach you on live patients in our 2-day program. I'm making an envelope flap without making any vertical incisions. And I found that I did have a little dehiscence right at where that tip of that root. So I have to protect that. Membranes. I've already mentioned that membranes are an important part of grafting with our materials, in that it will prevent invagination of soft tissue into the grafted site. It's a race between bone turning over and tissue ingrowth. One of my favorite products is EpiGuide. My second favorite product is CollaGuide. These are either a synthetic or a collagen material. It's very, very important, and you can get these through Golden Dental, and Kurt will talk to you about these. I think he has a package deal for you. These are my products that I use every day in my practice. Number one, it's important that you use a membrane that will last at least 6 weeks. So if your sales rep comes in and say, oh, I have a membrane that's a lot cheaper, you don't have to use that. The question that I want you to ask them, look them right in the eye, him or her in the eye, and say, how long does it last? If the answer is, I don't know, then don't use that product. The membrane must be intact for at least 6 weeks to allow that turnover of bone. These membranes will last longer than 6 weeks. They are resorbable, meaning you don't have to remove them later, and they can be exposed, meaning they're strong enough that the enzymes in the mouth and the acids in the mouth and the bacteria in the mouth won't eat them away. They will last probably up to 3 months, but I really just need the membrane to last about 6 weeks. The EpiGuide is a polylactic acid material that is just wonderful to work. It lasts a long time. Very little negative symptoms with our patients. So I'm going to slow down a little bit. I know I'm talking fast. When we have a defect, whether it be an entire facial defect or a small facial defect, and we're going to use a membrane, we must place that membrane at least minimally 2 millimeters beyond the defect. That membrane must be placed passively. One of the biggest problems that some of you may have is you've gone through these procedures, you did a graft, pretty much the way I did it, you placed the membrane, but the membrane came out during suturing, it came out before you had a chance to remove the sutures, and if that membrane does not remain intact for at least 6 weeks, the grafting procedure becomes unpredictable. I didn't say it won't work, I'm saying that it may not work, and that's the issue that some of you may have had here in listening to, in doing these procedures in the past. So here we're going to use a Allograft putty material from Golden Dental, and it is a demineralized bone. It's osteoinductive, which is important. Osteoinductive means we get stimulation of the progenitor cells, which differentiates into osteoblasts. It may have bone morphogenic proteins in it. So what that means is we get a better, faster turnover to natural bone. So you can see I placed my membrane, I'm injecting my graft material into the socket, and then I'm going to place my implant. I'm going to thread it right into my prepared site. Now my prepared site, again, I know this isn't an implant course, is not where the socket was. Remember that bone was very thin? I'm actually about 3 millimeters palatal to that existing socket. I'm going to place my membrane. Remember, it's engaged at least 2 millimeters beyond any facial defect, and it's engaged passively on the palatal. I'm suturing in the position, and you can see it's exposed. I'm okay. Taking my my post-op CT, you can see I'm palatal to the socket site. The site will heal. We will then make our impression. We use a material. I like to use a material from a company called Kettenbach. Again, you can talk to Kurt with Golden Dental about this product. It's sold direct, high quality, and it's going to save you between 30 to 40% of any polyvinyl siloxane material that you're currently using. That's a lot of savings for something you're going to throw in the garbage when you're done with it. We will then make an abutment and final crown, and you can see we can get an outstanding functional and aesthetic result. Another example, we have a tooth that's deemed non-restorable. How are we going to remove it? I'm going to use my serrated separator to try to separate the root from the facial plate of bone. If you're concerned with the thinness of that facial plate, I need to make a purchase point to place my beak so it doesn't slide off, and this simply demonstrates I'm not removing bone. Bone is gold. Rather, I'm flattening out the lingual or palatal aspect of the root, engaging the beak, and simply rotating my wrist, allowing that tooth to come up and out of the socket, very, very predictably maintaining that facial plate of bone, which is important to us. So you can see a very badly damaged tooth. We're going to luxate it and remove that tooth atraumatically without damaging the facial plate of bone. Again, we're going to curette. This is a particulate graft material, allograft material. And what I'm going to do is wet this with sterile saline. This is a cortical cancellous demineralized mineralized material that again will turn over a period of time. I'm placing it into the socket, and I'm able to make my osteotomy, thread my implant in position, and you can see how that graft material has surrounded the implant. Another allograft where we have teeth that are non-restorable, we're going to atraumatically remove those teeth. However, we're going to look at that socket, and remember, you must have facial plate of bone. This is the GoldenDent grafting kit. It's a wonderful kit that was put together. It looks good. It has every instrument that you will need, and again, it's very cost effective. We try to keep the cost of this this toolkit very, very nice. Here I'm using an Orban knife to elevate, creating an envelope flap, and I want you to see we have no facial plate of bone. It wasn't from the extraction, it was rather from the fracture of those roots. I'm taking my allograft powder material, wetting it, taking my EpiGuide membrane, cutting it to size, and you can see it's very passively placed. You can see I placed a couple implants. I'm going to graft the allograft material that's been wet, and you can see it almost becomes a gel. Passively placing my membrane into position, suturing it, and allowing it to heal. Those implants will heal for about 4 months, and you can see I have attached gingiva, I have healthy pink tissue. We can make our abutments and our final here. These are Bruxer crowns, and we're able to provide a great service. Another example where we have a mesial facial, a distal facial defect. Tooth is deemed non-restorable. We're again going to use our physics forceps. You can see a little purulence coming out on the facial aspect. I'm not ever squeezing the instrument. There's no force, no forearm, no bicep, no shoulder pressure. The tooth is removed quite easily. We're going to curette and evaluate. Look at that facial defect. We just can't place a plug in there, nor can we just graft. We have to be able to place the membrane correctly. So I'm taking my particulate, wetting it, cutting my membrane to proper size, making my envelope flap, exposing. I can immediately place an implant. I'm telling you, I can predictably grow a facial plate of bone around an implant that has no bone in it 100% of the time. But again, it's imperative that you use the proper protocol. You place your membrane beyond any defect. It's passively placed, and you make sure that membrane is intact for at least 6 weeks. You can see it's very passively placed. I'm placing my graft material. This will convert to a facial plate of bone each and every time. We'll suture it. Here's our implant. We corrected the defect. The patient was wearing a little flipper appliance here. 1 week post-op. You can see the membrane in place. You know what, I'll tell the patient the membrane is white in color, and tell them that it's supposed to be. Sometimes patients will look in their mouth, they'll think it's pus. It's not. Leave it alone. This is 4 months post-op. We're going to expose the implant. You can see the attached gingiva, the healthy pink tissue. We make a nice zirconia abutment here with margins at the gingival margin, and we do a nice Bruxer anterior aesthetic crown for this patient. So what about if we've lost bone? We see this all the time where we've lost the facial plate of bone. We have a concavity on the facial aspect, like this. Can we repair that? I'm telling you that we can do it using our allograft material and proper use of a membrane. I'm going to make my incision a little bit lingual to the central groove area. I want to use that attached gingiva that's on the crestal portion, and I want to move it forward. I'm going to make little penetrations into the bone, get bleeding points. Here's our GoldenDent allograft material. We take a membrane, we cut it to proper size. Here I'm laying my membrane, that becomes my new wall. I'm grafting the site with our allograft. I'm laying the flap passively in position, and you can see it's partially open in that area. But what did I tell you earlier? Epithelium grows very quickly. It's going to grow, and it's going to allow me in a period of time, in this situation, I probably let it heal for about 5 months. We placed our implant. Here we're doing a digital impression. You can see our healing abutment, the beautiful attached gingival, the beautiful periodontal health of my implant. We did a nice titanium abutment here with margins at the gingival line angle and a beautiful Bruxer crown, allowing that patient to function normally. We see this all the time. This is a challenge if you were going to do conventional crown and bridge work. Now I know there's a lot of work to be done here. We get to the conventional crown and bridge, but again, here we're going to expose the defect, and I'm going to immediately place an implant, and I'm going to graft that facial aspect. You can see I placed little bleeding points with a little number 6 or 4 round burr. I'm taking my GoldenDent graft material, placing my membrane passively onto the palatal aspect, and you can see how I plumped that tissue out a little bit. And over a period of time, in 4 months or 5 months, we've built a wall. I'm able to do my conventional implant prosthetics, make my impression, make my custom abutments. Look at the thickness that I was able to get with my graft material, the healthy stippling in my implant procedures. So this is what I recommend. This is what I use almost every day in my practice, and I place over 1,000 implants a year in my practice. So I'm preparing sites all the time. I do a lot of immediate placement of implants. I do a lot of site preparation where I don't feel comfortable placing an implant, but I can graft the site quite economically for the patient, yet very financially rewarding to me. I'll use an allograft material, and I showed you the two from GoldenDent, a putty, which is an injectable or a particulate. The OsteoGen plug when all walls are intact. The membranes that I use, I'll use Epiguide or the collagen membrane, again from GoldenDent. And you will get tremendous results. I know we covered a lot of ground in a very, very short amount of time. I know there's probably going to be a lot of questions from Lauren, and I want to provide you time to hear them. So I hope you gained some quick tips that you can use in your practice. I hope to see you at some of our courses at the university through Golden Dental. It's very, very important, and I can't stress this enough. Everything that I showed you is protocol driven. It's a step-by-step process. You cannot skip any steps. I know as dentists we like to skip steps. We can't let a curing light cure for 15 seconds to cure our composite material without getting impatient. This is, again, financially rewarding to you. It's professionally rewarding to you. It's fun to do. Your patients want you to provide them this high quality service. So I want you to do procedures that are predictable. I want you to know that when you start, you're going to get a great result at the end, regardless of how far you take it. So I hope you appreciate our time together. Again, Kurt can talk to you a little bit more about our live patient Amplify 1 and Amplify 2. And I'm going to turn it over to him and Lauren, and maybe we can answer some questions.
Great. Well, I'm going to turn the screen over to Kurt. As many of you know, we do these webinars on a regular basis. It's putting together a webinar for 800 people is not easy. It's not inexpensive. We definitely partner with some great companies to help put these together. And GoldenDent is someone that I've worked with for many, many years. They've been a great partner. I definitely wanted to bring Kurt on to make a special offer to everyone. And then we do have a bunch of questions, so I want to make sure we get to those questions. But I'm going to make Kurt the presenter and turn the screen over to him, and we will go from there.
Okay, thanks, Lauren. I appreciate it. Hello, everybody. My name is Kurt Lawler, and I'm with GoldenDent. We're a Detroit-based family business, if you are not familiar with our company. And I'll go through just a couple slides quickly just to go over a couple of the products that were discussed this evening by Dr. Kosinski, and then also obviously provide a promotional offer for investing your time with us this evening on the webinar. We do appreciate your time, and hopefully the webinar was valuable this evening. So a lot of the information we discussed this evening was regenerative materials. And if you are currently grafting, or if you're not grafting at all, I think we showed some options this evening, including the OsteoGen plugs, which is a great way to get involved in grafting if you're not grafting now, or even if you are grafting. It's a great option that's affordable and effective, as was displayed by Dr. Kosinski this evening. And if you are using a different brand of allograft, we encourage you to take a look at our GoldenDent brand. It is a high quality allograft, has great clinical results. And I think if you look at our pricing, it'll be competitive, and it's something to take a look at and consider in the future. So as described this evening, or I guess shown through clinical cases, the OsteoGen plugs they're around $50 normally. With the discount this evening, it comes out to about $42 a bullet. So it's an affordable graft. There's two sizes. You have a slim size and a large option. The large option can obviously always be cut into pieces, whether it's 2 pieces or 3 pieces, and shaped and formed into the slim size also. So the large size is probably the most popular, but there are 2 options for molars or premolars, whatever's going to fit best within the socket site. I think we've already described in pretty good detail how this product works. I just wanted to provide a quick note that we do have this product. It's a great product, and if you want to learn more about it, you can take a look online. So we do have our allografts. We do have the particulate in the putty form. We've already gone through this a little bit in detail this evening on the webinar. But we do have the allograft. It is unique. It's developed with a rice-shaped fiber technology, so the cut on it is a little bit different than a lot of the allografts on the market. And if you do visit our website, you can read a little bit more about our process and why our allograft is better than a lot of the other ones on the market. And we encourage you to take a look and consider the GoldenDent brands for allografts. Putty, same thing. Some putties in the market have different fillers in them. Ours is 100% DBM. So it comes in a syringe. It's a little bit easier to use, obviously, than the particulate, because there's not any mixing involved or prep of the product. But it's just another option or alternative than using the particulate. We do also have the putty available. The 2 membranes, these are both excellent membranes that were discussed by Dr. Kosinski this evening. The EpiGuide is our most popular membrane. It is a long-lasting synthetic membrane. I definitely encourage you to take a look at this membrane. It's a large sheet. It's 18 by 30, which is pretty large, so I think most dentists normally will cut the membrane in half, and it will cover, a couple socket sites. Based on the timing this evening, we didn't really have time to get into all of the unique and different products we have, but I wanted to quickly mention the Smart Dentin Grinder. This is an interesting product, and we have covered it in the past on different webinars. This is going to allow you to take extracted teeth and to harvest those extracted teeth to create an autogenous dentin graft. And so a lot of times in the past, autogenous grafts are not super popular, even though it's the gold standard of grafting, just because of the second surgical site and the inconveniences of harvesting bone from the patient. This is a good alternative to that, where you can use the teeth to create an autogenous graft. It's also affordable. If you have even one or two or multiple teeth that can be ground up in the chambers, it does make a lot of particulate dentin graft at a cost of around $49 per use. So it is economical for some larger cases. And you can see some videos and learn some more information about this product on our website if you're interested. I just wanted to give it a quick mention here. This is the Kosinski kit. As Tim mentioned, this is a kit that he uses in his office. It's a simple kit. It's economical. It's not expensive. There's various different instruments here, which you can take a look at on our website. But if you want to have a kit that is all together in the same cassette and ready to be used for each graft you may be doing in your office, this is an option to take a look at, just to have it all in one place and have it ready for your grafts. We also have some more advanced instrumentation, which would be scissors and needle holders and different instruments, which is part of our Flex series of instrumentation. If you're more comfortable with these types of needle holders or scissors, I just wanted to mention, take a look on our website at some of these instruments. They're more advanced than the kit that I just showed you, but it's something that we do have available. And each one is actually unique and quite special, if you want to take a little bit of time to read about why each one is unique. So Physix Forceps, this is the product that started our company back in 2007. It's still a very popular product for us, and I know a lot of dentists are having great success with the product. We hear the stories, each and every day from different dentists using the product. There's 4 instruments in the set. This would be an upper right, upper left, upper anterior, and 1 lower. This standard series set is our best seller, and it generally is going to cover all teeth in the mouth with the exception of third molars or wisdom teeth. In some patients, if you do have limited access or if they have a smaller mouth, it may be challenging sometimes to access second molars with this set, but it is a good set to start out with to see if you like the instruments, if they're a good fit for you. Our products always had 90 days to evaluate the product with a full money-back guarantee. We've been doing that for 10 years now, and it allows you to try the product to make sure it's a good fit for you. So if you can't get to the second molars or the third molars, that's what this set is really designed for. We have another set of instruments, which is a set of 2, and this is going to reach back to erupted third molars if you can engage the beak onto a solid 2 structure, and second molars that may be challenging to access with the standard series. So this set is normally an adjunct or an add-on to the standard series set, but if anybody's considering our instruments as far as the Physix Forceps, the standard series is a good place to start out. But these instruments also do have their use and effectiveness, but just more for like posterior teeth that you can't reach with the standard series. Tim already showed this slide. These are our separators. These have been popular for us too. So the Physix Forceps is an elevator, so we never really said you had to elevate in advance or do any preparation or elevation when using the Physix Forceps, because it is an elevator, it's not a forceps. However, a lot of dentists like to use an instrument to separate the tissue or to ensure that they're going to preserve bone for implant placement. And these instruments, if you take a look on our website, you can read more about what each one does. But these are great instruments to use in preparation to whatever extraction instrument you may use, whether it's the physics forceps or something else. But it's a good step one to start to prepare for the atraumatic extraction process. Lastly here, before I provide the promotional offer for this evening, we already mentioned our educational programs here in Detroit. We use the name Amplify Dental for our educational aspect of GoldenDent. If you want to learn more about our educational programs, you can visit amplifydental.com. There's a ton of information on there, hundreds and hundreds of photos of our past programs. We've been doing these for a number of years, and if anybody would be interested in these, they can take a look. Unfortunately, I think all of our programs are sold out, I think, for the rest of the year. I think we might have a couple openings for December 1st and 2nd. They do sell out, but if you're interested in getting on the waiting list for the 2018 dates, or if you even want to register and take advantage of the special this evening and pick your date later, there is that option available on the website where you can sign up now and then pick from one of our about 10 or 12 dates that we'll announce shortly once you figure out which one works in your schedule. So just real quickly, this is the classroom at the University of Detroit that we use. This is Dr. Kosinski in the day one lecture component of our AMP2 program, where we do some work with models and go over a comprehensive lecture before the live patient component on day two. You'll see here some of the attendees at our program are doing some work with some models. Here's the day two component, which is really why people come. I mean, it's all live patient. We always have over 100 to 125 plus patients, and we try to limit the program to no more than around 20 doctors each program. So again, here's another picture of the clinic floor. This is Dr. R. Nazarian, one of our other Amplify instructors. And so anyways, with that said, I'll wrap it up. I probably spoke longer than I should have, but I wanted to go over the promotion, and then I'll turn it back to Lauren for the Q&A session. So for investing your time with us this evening, we're giving a 15% off discount on anything available that we discussed this evening or anything on our website, including our education programs, which is Amplify. This is actually a great deal. It's better than actually the trade show pricing we even provide. And the promo code is DEAL15, so it's just DEAL 15. We do these specials that are 15% off. We do them, they're kind of quick specials or promotions. So we give you 24 hours after the webinar to take advantage of it. We just do kind of quick one-day promotions after the webinar. So it does expire tomorrow on the 20th at midnight. And you can learn more at physicsforceps.com, amplifydental.com, 15% off. Promo code is DEAL15, and our phone number's up on the screen. I appreciate everybody's time this evening, and I'm going to turn it back to Lauren to start going through the questions that have been submitted this evening, and I hope you can join us again on a future webinar.
Thank you, Kurt, and hopefully you'll stick around so if there's any questions about GoldenDent products that you can answer them as well. That'd be great. Thank you. Okay, Tim, we got a bunch of questions. You ready to do this?
All right. Let's go.
Okay. Yeah, and just so everyone knows, we have a hard finish at the bottom of the hour. I want to be respectful of everyone's time. We said the lecture, the seminar would be 90 minutes, and that's what we're going to do. What are your thoughts about grafting an infected site right after the extraction?
Great question. So, as I said in the program, when we remove a tooth, it's imperative that you curette. We want to curette any granulation and any purple blood, any soft tissue. I don't have a problem, Lauren, grafting a site that had been infected. And I like to use the analogy, if any of you have ever had a hangnail, you can be miserable. You're at Disney and you can't walk, it hurts, it's agonizing. So you go, you soak your foot, you cut the nail, and 5 minutes later you forgot that you even had any pain. The body's an amazing thing. So grafting a site that was infected is not an issue on my end. I don't place implants, however, if it's an infected site. I would rather let the site heal and then go back and subsequently place the implant at a future date. Great question, though.
Okay. Speaking about implants, how long do you typically wait after grafting before you would place an implant?
Well, that depends on the patient and depends on the quantity of graft material that you used. The smaller the site, the quicker it's going to change over. And again, remember, we're not pouring concrete that's getting hard. Rather, we're putting a material that will be eaten away by osteoclasts, and then osteoblast is going to lay down new bone. It's going to occur from the apex towards the crest. So what's nice about these products is you can take a radiograph and objectively see bone turnover. And it's always going to occur at the apex first. Depending on the size of the defect and how much material you used, as little as 3 months, never more than 6 months.
Okay. When you are plugging into the root sockets, does the septum of the bone in the molar sockets prevent adequate compaction of the plug down all into those root sockets?
Well, if you have two sites or 3 sites, you would cut the material and you can leave it connected at the top so that it'll go down each root. Or if you feel more comfortable, you can simply remove the septum with a burr.
Okay.
Great question. Mm-hmm.
There was a question. I guess you had mentioned you were talking about an enzyme in the middle of the presentation. What enzyme were you talking about?
It's called hyaluronidase. It's it's a physiologic response of the body. Okay, putting tension onto the periodontal ligament is going to release hyaluronidase in the body, which is going to dissolve the periodontal ligament, which is holding the tooth in place.
Okay. I think this is basically a follow-up, or kind of similar to the question we just answered before. The plug, you're opening the packaging, will it spread into the root space, or should you cut it and place it?
No, it's better if you don't cut it. That's what they look at. If you go to their site, you'll see how because it absorbs. It's kind of stiff. Okay, it's not like a collar plug. It doesn't turn to snot in just a few moments. It has substance to it, but it will, when you pack it, it'll absorb the blood, and it kind of fits to the shape of the socket.
Okay. Kurt, this is a question more for you. So during the, or maybe you know as well, Tim, during the training course, is there a specific number of extractions, implants, all the stuff that people get to do each time?
Yeah, I can take that, Tim, if you want. Well, implants, for the Amplify programs, we don't do implants, but I guess for the extractions, that's always a hard question for us to answer. I would say that some dentists are more aggressive and I guess efficient, or kind of want to move along with continuing to see, bring me another patient. So, I mean, there's a lot of dentists that'll do full upper, full lower cases. They will do, upwards of 20 plus extractions or more during the day. And then I think there's some that are more timid or a little slow to get going in the morning or kind of warming up, and, they may do, 10. But I mean, there's definitely the opportunity there. I mean, we're never, Tim can agree with me on this, we're never short of patients. And so we're always, we stay there until we get through the patients we have and the opportunities there. So to be honest, I mean, you can extract a lot of teeth of the program. It's hard for me to say a specific number, but I mean, people are going to do anywhere from probably no less than 10, and some people do upwards of 20 teeth during the day. I mean, you think it's a fair analysis, Tim?
Yeah, if I could interject there, I think that what our Dr. Nazarian and I really push, and Dr. Golden also, is the days are your days. It's the attendees' days, and we try to maximize the experience for the doctors. So if you want, Lauren, if you want to come in and you want to take out maxillary molars, we're going to try to give you those patients. If you want to take out maxillary cuspids and a fractured facial plate of bone, we're going to try to give you that experience. And before, right after lunch, I always like to sit down with all the attendees and say, did you get everything you want? Because if not, we're going to try to find you the patients that you want to see. It's challenging to do that, but I think we do a really nice job, and I think Kurt does a really nice job in providing the right experience for the doctors.
Okay. A few questions about the membrane. Are you placing it inside the socket, or are you placing it between the bone and the tissue? Between the bone and the tissue,
and it has to. That's what I do, and it has to extend minimally 2 millimeters beyond any defect. So if I have a 6 millimeter facial defect, I have to elevate that tissue far enough that I can place that membrane at least 8 millimeters onto the facial aspect.
Okay. In the at the course, is there typically any type of advanced work done? For example, like vertical sinus lifting. Is there any opportunities during the course for that?
No, Lauren. We don't really, we don't really do that. What we're intending on doing is practically training our dentists to, number one, atraumatically remove teeth. Number two, how to graft using, and everybody gets to use actually four different grafting materials, because we also use the dent and grinder that Kurt alluded to. We didn't really have a chance to do that in our lecture, and two different membranes. So we're demonstrating simple socket preservation all the way to building a facial plate of bone with these cases. So we're not doing sinus elevations or anything like that in that particular course.
Okay. Talk a little bit about both your antibiotic and pain med protocols post surgery.
Well, I'm not, believe it or not, Lauren, I'm going to be very honest. Number one, because I do so many implants, I don't block. I'm just infiltrating soft tissue. Bone is not innervated. Bone has no pain receptors in it for me to place an implant. Obviously, when we're removing a tooth, there's lots of nerves in the periodontal ligaments, so the patients are going to be sore. My regimen is a very low dose of amoxicillin, 3 days. 3 times a day, and most of the time it's 600 milligrams of ibuprofen. It is very rare that I would give a narcotic today, and because the procedures are really atraumatic, and I say that sincerely, the patients really do have a positive experience with the extractions of their teeth. There's no reason for any narcotic use in my hands.
Okay. With the membranes, do you ever find a need to secure it? You using like a tack or screw or suturing or whatever?
I have so many kits of tacks, and again, it's imperative that we place the membrane beyond the defect, and it's imperative that that membrane be laid passively. And you can see that in the diagrams that I gave, rarely do I make a vertical incision, and if I do make vertical incisions, I try to stay in attached gingiva. So I have really good control of my epithelium, and because that membrane's placed passively, I'm just suturing over the top. So, and you saw I can grow a wall with that without using tacks or metal frames or anything like that. So the vast majority of my cases, no, I don't use anything more than passively placing that. However, Lauren, that's not what dentists do. See, and I see this all the time. We don't make a proper elevation of the epithelium, and therefore we try to force that membrane to go into an area that it's not going to go into. So we end up laying it on top, and it falls out. Once it falls out, the case is no longer predictable. It may or may not work, and I don't want that. I don't want to know that it may or may not work. I want to know that what I'm doing is going to work.
Yep. Kurt, the tuition for the course, is that something that they can get the information about it by calling? Is this something you give on the webinars typically, or if they have a question about that, would it be just best to contact you?
Yeah, I mean, it's all on Amplified Dental, but I mean, to answer the question, I mean, AMP1 is a 1-day program. We do extractions, and we provide the opportunity to use the OsteoGen plugs, maybe once or twice. We don't do really grafting in that program. We just do the simple socket preservation with OsteoGen. That course is the regular price before the 15% off discount is $9.95. And then our AMP2 program, which is a 2-day program, where it's day 1, 8-hour plus lecture, and then day 2 is all day on the clinic floor, starting first thing in the morning. That course is it's right around $2,400, and again, we use a lot of materials that we provide. We provide the patients. All of our programs, you really just have to show up, and we have it all organized for you.
Okay. This question is a little off topic, but I'm just going to read it the way that it's written, Tim. I have a question not about grafting, but on your implant crowns. Did you prepare the abutments and take impressions as you would with a normal crown and bridge? I asked because I noticed you said you prepared margins at the gingival margin.
The lab does that. No, I don't prepare my abutments. The laboratory will do that. I work with Glidewell Lab, and I found I don't have to put my margins subgingival, and we get really good aesthetic results.
Okay. what happens if you do fracture that buccal plate? I don't realize it doesn't happen very often with the physics forceps, but what would be the regimen at that point?
We're going to graft it. We're going to place a membrane, and we're going to repair that facial bone.
Okay, and for how long before you'd go back in there?
Well, 4 months on average.
Okay. Okay. Sort of a follow-up to that, what's the main determinant as to whether you place an implant at the time of extraction or the graft and wait?
A great question. I do a lot of immediate placement of implants. We need initial stability. So if I can use an implant and I can extend it beyond the apex of the extracted site and get initial stability, then I have no problem placing an implant immediately. Obviously, it saves a lot of time in doing that. And again, if there's an infection, I don't put an implant in immediately.
Okay. What was the name of that buffered lidocaine that you used that has the 7.2 pH?
Anutra, A-N-U-T-R-A, and you can talk to Kurt about at Golden Dental about that.
Okay. And what type of ceramic is the buffer crowns?
I'm sorry. I'm sorry.
Yeah, and the reason the question is, what type of ceramic is the buffer crown?
Okay, those were Bruxer is zirconia. It's a zirconia crown.
Got it. Okay. Let's see here. We want to make sure we get to as many as we can. We've already done. Billing. Can the atraumatic extraction be billed out as a surgical extraction? Because the definition, it does not involve any flap raising or sectioning of the tooth.
I don't know. Good question. I'm not sure how we fill it out, to be honest with you. I think that, if I use the physics forceps, and again, I don't take a burr to it, right? If I'm not removing bone, then I would call that a simple extraction. If I'm taking a burr to create a purchase point on the lingual or palatal aspect, I think that becomes a surgical extraction.
Okay. Do you recommend sectioning molars to preserve the walls? Do you try to place immediate implants in molar sites and graft around them?
Great question. And I never place an immediate implant in a maxillary molar tooth. I would always graft it first. It's not in the aesthetic zone, number one. I would always graft it first, trying to minimize any collapse of the sinus area, and then I would go back and place an implant, say 4 months later. But I do not place an implant immediately in 3-rooted molar teeth.
Okay. What about provisionalization? Can the patient place a flipper right after the graft is placed? Will the pressure affect the graft and possibly cause it to fail?
Well, it depends how the flipper's made and how extensive it is. If it's extensive, then I would use a soft liner material. Otherwise, I would make the appliance so that it is not engaging, putting a lot of compression onto the grafted site.
Okay. Slightly off topic here, more for Kurt, but when the patients that volunteer for those courses, are they getting those implants at a discounted rate?
Well, for our programs, it's extraction and graft. So the dentistry that we do here for the patients at Detroit, it's all free for the patient. So we've actually, beyond being an excellent course, we've been providing a really great service for people in need for a number of years here in the city of Detroit. I mean, we've seen, thousands of patients over the years at these programs. So the dentistry for the patient is free.
Okay. That's good to know. That's actually great to know. For Tim, how do you determine what particle size you need for the grafting?
It's pretty standard. And it's what I'm used to using is 250 to 1,000 microns. I find that it's easy to manipulate, it's easy to compress without crushing. And you want a variety of particulate size because you want the turnover of bone to occur over a period of time. So if you have all small particulate, it's going to resorb too quick, and I don't get the bone formation that I want. That's a great question. Yeah.
Okay. Any preference? Do you prefer putty or particulate, or does it depend on the case?
In my hands, Lauren, I do grafting just about every day. So I've gotten to be very competent. I have a DAP and dish in our grafting kit. pouring my graft material in and wetting it with sterile saline, letting it sit for a little bit. It turns into a putty. I have a very well-trained staff. They carry it to site. But for simplicity, obviously taking a syringe and just squirting it into a socket is it can't get any simpler than that.
Yeah.
I think that's probably a little more expensive to do it that way, but it's your, and what's nice about the package that GoldenDent means a lot to us because they're they're Detroit based and they're family owned, and they want us dentists to be successful. They have money back guarantees. Nobody does that anymore. It's a wonderful company to work with. And the best thing to do in the course, that's why we let you use the variety of products. And then at the end, you can decide, oh, I like this the best. This is what I want to buy. And then they package things for you so that you can feel comfortable with what you're purchasing. We don't want you to purchase anything that you're not going to use. Okay. So we want you to be successful, make money, be professionally satisfied and stimulated, and grow your professional life.
Yep. I think that's a great way to approach it. A couple more questions, and then we're going to wrap it up here. You were talking about the maxillary molars. Where do you place that implant? Are you putting them diagonally into the palatal root? Because obviously the bone's a little bit limited up there.
I don't place an implant immediately in a maxillary molar. I would graft it, and then I would place it ideally along the central grooves, central, mesial, and distal. So I don't place immediate implants in maxillary molars.
Okay. How long do you leave your vicryl sutures in before removing them?
Well, vicryl, they will last about 21 days. I bring all my patients back 7 to 10 days. And the reason I do that, and I'll tell them ahead of time, most of our patients, I said it's atraumatic extraction. They don't experience a lot of discomfort. I'm just giving them 600 milligrams of ibuprofen. They will do really well for the first 3 or 4 days. And if you don't tell them, they will call and say, I was doing really well, but something's wrong because it's starting to bother me. Well, the epithelium wants to close and the stitches are acting as an irritant. And so I bring the patient back 7 days normally, 7 to 10 days if they're on business trips or whatever, to remove the sutures. I just want time for the epithelium, remember it grows a 0.5 millimeter, 1 millimeter a day, to kind of hold down my membrane to keep it in position.
Yep, makes sense. We're running out of time, so I wanted to give you, Tim, a minute or two to say any parting words here. Have Kurt wrap it up, and then we'll call it a night. Well,
Lauren, I respect you so much, and I truly appreciate your time with me. I think you just do a wonderful service to the profession, and I just wanted to acknowledge that for a few seconds. I want to thank Golden Dental for sponsoring this. Again, we support them wholeheartedly. Made in Detroit type of thing, and we're very proud here. The city's booming. Our Tigers aren't doing so well, but we have hope for the future, and we hope to see some of you at our courses at our university soon. Thank you.
Great. Kurt, anything you want to say before we wrap it up?
I don't think so. We're here if anybody has questions. Give us a call anytime. More than happy to help determine which products might make sense for your practice. I appreciate everybody's evening.
And I appreciate both of you. I've had the pleasure of doing webinars with Tim for a number of years. I always learn something new. It's always great new content. It's fascinating, and obviously by the turnout that we got tonight, a lot of people are interested in what he has to say. We are very thankful for the very generous sponsorship and participation of Golden Dental. They are a class act. Many of my clients over the years have worked with them. I hear rave reviews about the courses, about the products. This is a company that truly, they say what they mean and they mean what they say. And they're going to 100% support you in your efforts to add a very necessary service for your patients. So thank you to Tim. Thank you to Kurt. We do these webinars on a regular basis, so we hope to see all of you on future webinars. We appreciate your time, and as I said, you will all be getting a link to the recording sometime in the next hour or two. The CE will be done over the next few days, and please feel free to reach out to me or to Kurt if you have any further questions. Thank you all for joining us tonight, and we'll see everyone in the future. Good night, everyone.
Good night.